and I hope you'll find it of some help. So here we are. This is based essentially, I was asked to speak at this meeting, Indo-Cleft meeting, and this was my introduction to them. So it may not be accepted by some, but that's okay. You're all entitled to your opinions and your treatment plans because it works in your hands. And this is just my philosophy of treatment. So here we are. I saw Gubish do correction of nasal alar deformity using a VY advancement. Horrendous scarring result at the margin. Prof. Mokel, who I have the immense amount of respect for, he does a transposition flap to correct this alar hooding. Again, I'm not sure it addresses the problem of the alar hooding and the lack of alar support. And I wondered if this could be modified into a more tissue-sparing procedure. Whatever you do, the deformed alar rim lacks support. You know, you plonk a cartilage piece on top, you hope that it'll work. It doesn't. So here we are. These are my techniques. The first time I did this was in 2008 with Dr. Gopal, who I believe is a colleague of yours in Coimbatore. He's a maxillofacial surgeon with an interest in clefts. I did that first time in 2008. So these are the categories of patients who are amenable to these minimally invasive procedures. One is a virgin cleft where no one else has attempted to do anything. Second category, previous surgical interventions. Third, previous attempts at revision. And then previous secondary and tertiary. You know, these patients go around place to place every time a surgeon does something. And then lastly, the residual deformity from surgical mutilation. And I see a few of these. I'm sure you all do. So let me just show you. Here's someone who's had a cleft lip repair in childhood, but never had her nose addressed. She was, you know, happy. You can see the deformity, the alar hooding. The most thing of concern to her was the alar hooding. You know, it looks like, someone asked me what alar hooding was, and that's why I put a picture of this king cobra there. That's what alar hooding is all about on this side. And then there's previous surgical interventions. This patient was treated in somewhere down Cape. What's the southernmost part of India? Yes, somewhere there's a surgeon who does these procedures. And this was his fourth or fifth attempt with his residual problem. He has no projection. He has lost his columella. So there you are. Here's another one who was treated in Libya by another colleague. And I can't understand how a cleft patient primarily has a forehead flap, which this girl had. I don't know. I simply don't know. Even that hadn't addressed her problems. She still has this central lip deficiency and a nose which she cannot breathe from or doesn't look aesthetically pleasing. And then previous secondary and tertiary procedures which have left the patients with considerable amount of discontent. That patient was done in Calcutta, who came to see us after having had multiple procedures. And then residual deformity owing to failed previous surgeries. I think smile trains are done very nicely by nice people, but there are some not so nice people who do things that shouldn't be done. And I think, you know, good luck to them. But poor patients, I feel very sorry for these patients because they trust us, and I really think we should do them no harm. And here's someone, this poor woman, so unhappy with her appearance, and you can see the sadness in her eyes. So, what are the problems involved? Scarring, external, endonasal, deficiency of skin and lining mucosa, Loss of structural support. You do need rigid structural support for cleft noses. It won't work if you put in cartilage graft from the ear. It doesn't work. Yes, it can if you want to reconstruct an alar. Yeah? And septal deformities. Owing to the cleft deformity, a consequence of previous surgery, or some people harvest grafts from the septum in a cleft patient. I think that is not advisable unless they have a very big, large, robust septum. So, here are the problems that I have encountered. Tip deformities, asymmetry, and loss of projection. One thing, I'm sure you guys don't do it anymore, alotomy, when they do the Millard repair, they skirt the incision around the alar facial crease, and that permanently destroys any future hope of normal alar facial development. And I pray to people that they stop doing this, but you still see this sad problem. Yeah. That's why I always say to you, don't be in a hurry to do alar base excisions, because it's an irreversible procedure. Yeah. Tiptosis and underprojection. That's the other problem that you encountered. Tiptosis and underprojection. You see, here's ptosis. He has got enough to project. This girl has underprojection because she's got deficiency of cartilage and soft tissue. And here's, again, a combination. Tiptosis with alar hooding and alar malposition. Again, that sad incision going through that alar rim. She's a lovely girl, a school teacher, vibrant, lovely girl. And there's this deformity which causes her much distress. Alar hooding, as you call it. So, how do we overcome these problems? These are the goals. You start to straighten the foundation of the nose. You start building your house from the foundation upwards. Then you straighten the septum. And then you straighten the dorsum. And then restore dorsal height. And then go on to tip projection. You project the tip first and then restore asymmetry. And then when you've done that, you can rotate the tip according to the need. And then correction of alar deformity, and make sure at the end you have establishment of a normal columellar lobule relationship, 2/3 to 1/3, wherever possible. And establish a normal lip-tip ratio, 1:1 ratio. Look up a paper by Athir Ujam, one of my registrars, now a colleague at King's. He and I did this paper, lip-tip ratio in correction of cleft lip nose. Okay. So, here we are, straightening the scarred nose. Previous septal surgery and septal graft, you can't do it. You need a septal extension graft via hemitransfixion. You can put in this graft and suddenly you have a new nose, a new projection. And you also see callus formation following osteotomy. This makes further procedures difficult. And there we use a costal cartilage graft for the dorsum, or scar dermis. That's an excellent substitute. Scar dermis graft, camouflage. There it is, you see. My colleagues in plastic surgery at the London are about to write this paper. Look out for it. Scar dermis graft. Restoration of dorsal height. Again, access to dorsum via unilateral intercartilaginous incision and costal cartilage fusiform graft carved in a sleeve of fascia, like you saw me before. Yes, someone was asking me, can I use discartilage? Yes, you can, but you need to put a graft in a short nose under tension. With a discartilage graft, you cannot get the tension. So you need a fusiform graft unaltered. So that's the difference. Or deepithelial scar, but you'd need scars in the body elsewhere to do that. Is that okay so far? Right. Now, correction of alar rim deformity and hooding. This is my technique. I make a tunnel. We're using a Watson chain probe or a urethral dilator. I make a tiny stab incision there. I make a tunnel there. I split a 10th rib or any of the rib. If you split it, it intentionally warps and deforms to the size you want, to the shape you want. and I thread it through, and that gives you the ideal nostril shape and support. You don't get that with the alar reposition. You don't get it, but you do get it with this. I urge you to try it. Okay? Sadly, we didn't have any cases do that, but I did do them with Dr. Calder when I was in this. You see, stage correction of asymmetric alar base. Make sure the base is right in this type of deformity. Correct the alar base. That's the base, and that's the pedestal. Those two are essential before you do other things. You see, you raise the alar base on the cleft side with a cartilage graft. You can access them via the existing lip scar. You can access the alar base. Restoration of tip domal alignment, either by delivery technique, as you saw me do yesterday, creation of a dome, or lateral crural adjustment. Now here's someone who's had an alar batten graft put in. Here's this girl with an alar rim deformity corrected. Again, through her original lip scar, a strut was put in and an alar rim graft placed in. That lovely girl that I showed you before. That's her before. You see the deformity and the hooding and the tiptosis. This is what was done to her. You always write your notes so that and this is what she looks like a year later. You see, I can't do anything about this sad peri-alar scar, but at least she's better. The tiptosis has been corrected. She's got good profile, good projection, and normal looking alar. Only her husband and her dog can see that discrepancy there. You see, there's the difference. Here's an example. This is a patient who was referred to me by Professor Senthil in Chennai, and he just wouldn't go out of the house. His father said he just doesn't want to go out. Sad. So he had a septal extension graft, and a dorsal graft, and a strut through minimal invasive incisions, tiny, tiny incisions. Some improvement. At least he says, the father says he goes out. You see, he's had all this scarring from previous surgeries elsewhere, not by Dr. Senthil. So, esoteric methods. Yes, I am an esoteric person. I went and saw Professor Turner Warwick, who has his own modification of the Clutton's dilators, and I said, I seek your permission to use your called his wife aside, said, Margaret, look at this chap. He's going to put my urethral dilators up the nose, he said. So that's one. The Watson chain dilator that I use often makes nice little tunnels. Now, if you split a rib this way, look at that deformation you can get. You can make an alar out of it. You can make whatever you want to out of these split grafts. These are the esoteric methods. Sandpaper, existing scars. I use the scars to access and spinal needles to help railroad fascial grafts. So, in summary, this affords a foundation layer. It forms a foundation layer, the minimally invasive technique, and then later you can do an aesthetic correction if required. Most patients are happy and they go away, but you can do more. And they cause very little morbidity in terms of residual scarring or tissue resection. And the next surgeon can work without fear of more scarring or problems. Okay, any questions on that before I do the next talk? Okay? All right. So let's do the next one, please. Yeah. This again is a topic of considerable importance to me because people have been fixed in their ideas, but I'm sure the new generation are different. Here was the dictum that I was brought up on when I was doing early plastics training. This is the dictum, isn't it? Early procedures will damage, interfere with normal growth. Do not correct nasal deformity, as the headmistress standing there, Rosa Klebb, telling you to do. And most of these patients grow up to be freaks. You know, they're psychologically disturbed. Yeah. Then, in 1992, I went and worked with Professor Verwoerd in Rotterdam, and I learned a lot more, the revolutionary concepts about the growth of the nasal septum. And he's highlighted that pediatric nasal deformities can and should be corrected, subject to correct principles being followed. You know, he showed the septal growth. You see, this is full-term baby, all cartilage, 6 months, 6 years, and an adult. You see, this is how and you have the potential to either help them or hinder their process of growth. And you've all heard of Autis Ministerius, one of the pioneers. I remember going to Mexico City in the late 80s, and every Saturday he would go up to villages and bring in young children to do. I thought he was crazy. Not. He was helping them. He was saying that failure to correct this will worsen morphogenic deformities of the nose, palate, and midface, and also psychologically affect them. So this has been evidenced in cleft lip nose, Binder's nose, and mid-vault nasal trauma. Both these chaps have done extensive work on this. And these are my little additions: improvements and refinements in surgical techniques and instrumentation, esoteric techniques, use of existing scars. Use old scars. Don't make new incisions. Old scars, and access them through your cleft lip incisions or through your alotomy incision. Just use that, yeah, to your advantage. Use of Clutton's dilators for tunneling. If you're going to a sublabial approach to augment the premaxilla, look at that. Putting a Clutton's dilator, look at the projection you get in a Binder's nose. That tells you what you can achieve. Modified costal cartilage grafts to correct more severe structural deformities. Split the cartilage, the 10th rib, look how it deforms. Desired bend, you can make an alar and a columella, both. Remember, please, do no harm to your patients. Yeah? What are the indications in children? Those: bifid nose, cleft lip nose, midline cyst, Binder's, nasal trauma. You must intervene. Severely deformed. This girl, parents said she wouldn't go out of the house. 9 years old, stuck in a room, teased at school. Lovely child, wouldn't go to school. Freak, they called him. Yeah. Midline cyst. He's been seen by an eminent professor in Tripoli who said no treatment for the nose. Look at him. He started off, and as time went by, his destruction of the upper lateral cartilage and the sept on that side, he's got entire retraction. By the time he's 12 years old, he's psychologically disturbed. You do need to intervene early. Binder's nose and maxillonasal hypoplasia. You need to treat these people early. Nasal trauma, early saddling, you must intervene. If you don't, you will get a shortened nose. The nose will not grow. You see, these people have been advised by some wise colleagues, no operation until you're 17. He's 12 years old, he's got an established, this is not going to get any better. You need to intervene. Look, this boy's parents have been told, don't let any surgeon touch you. Look at this guy. I've been following him for 3 years. They won't agree to an operation because the wise professor has said no operation. This is the nasal septum. This is what it does. It's a central column. Yeah. This, very important, before they go to school, before they get psychologically upset. This is the choice. This is how the septum grows. Did I show you this slide before? When a child is born, the lower lateral cartilages cover this midvault completely. If you have at this stage a septal hematoma or destruction of the septum with an abscess, the nose will not grow. You will get an infantile nose. Look at this. I've followed this child till he's an adult. He's a son of my plastic surgery colleague in Tripoli. And look at him as he's grown over the years, how the nose from there to there. These are the surgical canons that you must observe before you do these operations. Incisions and decollements. You understand decollements? Division of cartilage from one to the other. Must be as limited as possible. Strictly limited unilateral you can do both sides. But preserve the chondrovomerine junction. Do not disarticulate, because that's where the growth center is. Do not separate the upper laterals from the septum in a growing child, because the septum grows uncontrolled growth. If you have a luxated basal rim into one of the nostrils, you can correct that without causing impunity. If you have a bony vault deformity, you can use a green stick basal osteotomy by the external technique taught to me by Mr. Bull that we've used. And if you have a fractured septal cartilage, you must try and reconstruct it either with a cartilage graft or with PDS sheet so that you maintain the height of the septum. Look up a paper by Eugene Kern on pediatric nasal injuries and you will see his views on that. If you do septal surgery, use magnifiers. Hemitransfixion, you can do one side or both sides. Don't elevate the periosteum on the nasal floor because the growth will be affected. Modify the transfixion. Reconstruct cartilaginous septum to prevent scar formation. Here we are. Use scars. This girl had quite a nasty septal injury. She had a scar there. I used that to access her septum and the dorsum, just from there. Child with a cleft, previous scars, used those scars to reconstitute her columella and her ala. You see, this is what you do not do. You can do this in adult septum, but not in a child. Do not do this. Do not separate the upper laterals. Correction of alar defect. See, make a tunnel and you can create an absolute thing. But after you've done that, you need to put in a conformer for a little while. If you have a severe deformity, you can do a Abbey flap at the same time as you project the nose. Using the prolabial skin, you can make a new columella. That you must correct. Now, this is something my colleague Navin Vig is writing up for me at the moment. This was described in 61. You have these features. And you see, it may occur in isolation or with a cleft lip nose deformity or in association with a dentofacial deformity, either. This is the first case I did in 2011. He was a 9-year-old boy. They'd missed a boat. He was teased at school. Nice boy, nice family. Look at that. He's got this features. He hated it. So, first stage, lengthening the columella using a composite graft from the ear, from the antihelix. See, a composite graft. Handle it with care, and that lengthens the columella. And then, stage 2, a tetracartilage graft. Septum, dorsum, strut, and pyriform base. Those are the 4 grafts you need for Bender's correction. And you cannot do this open because you need tension to lengthen and heighten the nose. Through a small intercartilaginous incision, augment the dorsum. Through a sublabial approach, you're going to augment the premaxilla. Use that approach to get into the septum, septal extension graft. Strut, again, to the base of the lip. You can also make a tiny incision like I showed you yesterday at the base of the medial crus, but this is where if you've opened up, you've got. And a piriform, the premaxillar augmentation. And write your notes. Whatever you do, make your notes so that anyone else who sees these patients are aware of what you've done. And never let someone else write your notes. Write your own notes with pictures where necessary and give them to your patients. So if they go abroad, if they go somewhere else or see another colleague, they'll know what's been done. And that's him a year later. And that's him 5 years later. And that's him 9 years later. You can see that the growth of this, some of these cartilage grafts, they do grow. And it's growing a little bit erratically. He's coming in for a shave. Sadly, he's also developed lymphoma. He's undergoing chemotherapy at the moment, so we'll do that. That's his hairstyle, not a coronal flap. That's just his hairstyle. He's combed his hair and made a plait out of it. This girl missed the boat. She came when she knew that her neighbor had it done. She came to see me. She was 22 years old, a girl from Mauritius. And this is at operation. See how you get the projection to the tip with a sublabial approach, putting in a strut graft, a robust strut graft from the rib. And we had to fix her a dorsal graft because it wasn't stable. It was very flat dorsal and the graft was slipping all over the place. So, in summary, you do need to address these to assist with normal growth, to prevent psychological problems, more importantly. Very conservative approach and staging. Any questions? Yes.
In this syndrome,
Yes.
we had to stack up layers of grafts to get a great prediction.
No, just the central strut. Yeah. This is where the 10th rib is of Mars.
Right. So I asked because I had one patient who was a bit unhappy with the first projection.
Yes.
So came back. So I put a second graft underneath, but it would slip over the other.
Yeah.
So I put the spins down. And that worked very well.
Use a 10th rib.
Oh, okay.
Right,
Yeah, that's a good idea.
Sometimes just put a 10th rib in there,
Yeah.
and you can go back and put a dorsal later. That bit they don't like is that short. And that also helps to lengthen the columella.
Yes, yes, it does. Yes.
Okay. Any other questions? Well, it's been a pleasure having your conference with you, and I hope we meet again. I'm conducting a workshop in Chennai in November, and in where are we going? Chennai first, and then we're going to Cochin. So in November from 4th until the 9th, we've got 2 workshops. You're welcome to apply. I've also got a workshop in Cyprus in May. That's entirely lectures and video demonstrations. Yeah. Okay.
So
Thank
what
you
you
all.
have done is a great service for us. We thank you very much. And what we have seen is a work of art, a thing of beauty and a joy forever.
Thank you for your kind words. Thank you. All right. Thank you. So you're turning back whenever you
I say thank you to my team, Professor Rai sir, John sir, Madam Govardhan madam, plus also the hospital MD Dr. Abdul Salam sir, AB Shiva sir, the other staffs, all the supportive workers, my managers, staffs helping us to projections. Yeah. Thank you one and all for helping.
Later.